This programming is brought to you by Boehringer Ingelheim Pharmaceuticals Incorporated. Heart failure guideline-directed medical therapy offers an opportunity to provide better care for patients, but significant gaps in uptake remain. Now more than ever, it's time to pump up GDMT for heart failure. Leaders in the cardiology community recognize this need and are asking you to do the same. Visit pumpupgdmt.com to learn more. Together, we can help ensure guidelines are enacted and patients receive quality care.
Worldwide, cardiovascular disease affects the lives of hundreds of millions. Dedicated CardioNerds everywhere are working hard to fight this global epidemic. These are their stories.
Hello, everyone. This is Amit Goyal. Thank you so much for tuning into this profound episode about taking care of patients with adult congenital heart disease. ACHD clinicians don't just treat interesting anatomy. They bear witness to individual lives. From childhood through adulthood, they walk with their patients through uncertainty, resilience, heartbreak, and hope. This episode isn't about guidelines or procedures. It's about the human stories behind the medicine. It's about the weight of grief, the courage in high-stakes decisions, and the joy of hard-earned victories. If you've ever wondered what it means to truly care in cardiology, friends, this one's for you. This episode was organized by the CardioNerds ACHD Council and planned by council members Drs. Rawan Amir and Cambron. Let's dive in.
Today's episode takes us into the realities faced by providers caring for adults with congenital heart disease, an area where medicine meets humanity in its most vulnerable moments. Imagine following a patient's journey from childhood into adulthood, celebrating milestones, navigating setbacks, and forming bonds that make you feel more like family than a provider and patient. Now, imagine the weight of losing that patient far too soon, despite every effort and intervention. For many ACHD providers, this is not a rare occurrence. It's an emotional reality they face regularly. Whether you're a physician, a nurse, a medical student, or simply someone curious about what it takes to work in one of the most emotionally charged areas of medicine, this episode is for you. So, let's get started.
We are thrilled to introduce the phenomenal faculty joining us today, which includes Dr. Jill Steiner, Dr. Allison Tsao, and Dr. Katherine Salciccioli, each bringing a wealth of experience in the rapidly growing world of ACHD. Dr. Steiner completed her internal medicine residency at Georgetown University before moving to Washington State, where she pursued cardiology and ACHD fellowships. With a special passion for palliative care in congenital heart disease, she furthered her expertise by completing a research fellowship in the field. Her dedication to improving the quality of life for ACHD patients makes her voice invaluable to today's discussion. Dr. Tsao is joining us from the East Coast, having completed her internal medicine residency at Johns Hopkins Hospital. She then moved to Boston, where she completed fellowships in cardiology, interventional, and ACHD. She now spends her days performing complex congenital interventional procedures at University of Pennsylvania, helping shape the future of ACHD interventions with cutting-edge techniques. Dr. Salciccioli joins us all the way from Texas. She completed internal medicine, pediatrics, and pediatric cardiology training at Baylor College of Medicine, then further advanced her training in ACHD at the University of Michigan. She has a special interest in the intersection of ACHD and cardio-OB, ensuring optimal care for patients navigating pregnancy with congenital heart disease. Together, Dr. Steiner, Dr. Tsao, and Dr. Salciccioli bring a diverse range of perspectives and expertise to the discussion today. We're incredibly excited to have them share their insights on this very challenging topic. Now, let's dive in.
Dr. Steiner, you offer a unique perspective with your background in both ACHD and palliative care. How do you think the long-term relationship between patient and healthcare provider in ACHD care differs from other specialties in medicine?
I think there are a number of differences here, and not only between ACHD and medicine, but also ACHD and other cardiology subspecialties. In some places, the ACHD clinicians take over the care for their pediatric patients in smooth continuity from the pediatric setting. Sometimes it's the same people. In other settings, it's not. It's a completely different team. In both situations, We need to establish and maintain the trust that underlies the physician-patient relationship, or the clinician-patient relationship, I should say, because it really helps us connect with our patients when we're thinking about things that are going to happen very far in the future. One of the hardest things I encounter as an ACHD physician that takes over the care of people transitioning from a children's hospital to an adult hospital is being like, hey, it's great to meet you. Everything looks good now, but you might need a heart transplant in the future. And that really freaks people out. Understandably, I'd be freaked out, even if I've heard of it before. And the thing is that many people have never had this conversation before, despite our pediatric cardiology associates' best efforts. It's just not heard, or it doesn't feel like something that's going to be personally relevant to a lot of kids and teenagers when they're otherwise feeling well. And I think it's really that establishment of trust and continuity, even though we're a new team or even though we're talking about different topics or a new phase of life, that really is going to carry things forward all the way through. And it really makes the other conversations that we have about medical engagement, about taking your medications, about coming to appointments, about planning pregnancies and planning big trips, planning moves to new places where there may be different or zero ACHD providers. It makes all of that much easier if we have that underlying relationship that we can have a conversation about these things without feeling awkward or feeling unable to talk to each other. So that continuity of care is really the major thing that we're trying to maintain through trust and the emotional bond between a patient and clinician. Transition between the pediatric to adult setting is recognized as one of the most difficult things that our field faces right now. We have lots of great ideas borrowed from other chronic illness groups whose diseases have been around for much longer and who have been much more stable, and they haven't even figured it out. And so, with this constantly changing and still changing ACHD landscape, we have a lot to learn and we have a lot to do to develop the ideal transition period. So, really thinking about how we're going to be not only their ACHD physician, but also their sounding board for general questions. We get questions all the time about patients whose PCPs or therapists or GI docs want to start a new medication. And is this okay? Is this okay just because I have congenital heart disease? Is this okay because it's going to interact with something I'm taking now? Is this okay because is it going to cause a problem in the future? And those questions don't always have really easy answers. And much of what we do in ACHD is talk about uncertainty and the fact that we are basing our recommendations on what we know. But what we know is not huge compared to other subspecialties, and it's progressing and changing and growing along with our patients. And really, to talk about any uncertainty, we do cite trust and openness and really center vulnerability in our discussions.
Thank you for that answer, Dr. Steiner. That was really thoughtful, and it made me kind of reflect on a lot of the instances I've had in clinic where I'm trying to establish quick rapport with patients who are coming in with really challenging things happening in their lives. How do you balance forming deep connections with patients while preparing for the possibility of difficult outcomes? And how do you approach patients' loved ones when having these challenging conversations?
I think a lot depends on how you already interact with that person and how you anticipate interacting with that person in the future. It is hard to form an immediate connection when you meet someone for the first time, but that's what we are trained to do. We're trained to walk into someone's room and have sometimes a very directive conversation with them before we know anything about each other. And I think that's even more amplified in ACHD because often we're having big conversations about things before we have gotten time to have multiple visits or spend time with each other. So I think it's really important to start by asking people what is important to them and who is important to them, because you want to make sure that you're centering your conversations about the future and also your medical recommendations around what they think is important. Because if you're not connecting with the rest of their life outside of that exam room or that telemedicine square, your recommendations are going to be nothing. And if you don't include the person or the people that they trust to be their additional set of ears, to be their voice when they don't have one for whatever reason, then your recommendations are going to be discounted as well. And a really great example that I love to bring up in this situation is actually in our cardio obstetrics clinic. We have a congenital heart disease patient who lives up in Alaska on an island. And our recommendation was like, yeah, come down here a few weeks before you're due and we'll arrange everything. And when you're ready, we'll induce you and, make sure you have a successful delivery. And she was like, no, I have animals and I have another kid and I have no one else that is going to take care of them when I'm not there. And also, by the way, it is winter and I can't fly off of my island in Alaska to your medical center when you tell me it's time. And that very frank recognition of the fact that our recommendations can't exist in a silo was really powerful for all of us. And I think it reminds us and continues, this was years ago, it continues to remind me that we need to know where our patients are coming from before we can really do anything that's going to truly prepare them for what might be a difficult future. Similarly, our patients who are facing heart failure or transplant or worse, transplant option is not available. And then we have to walk them through that long road of end stage heart failure. We need to know who's going to be there for them and who's going to help them and what services they need. Because I think many of our institutions are similar when I say that we don't have as many wraparound services, as many social services and home health opportunities as we would like. And it really does behoove us to know who our people are outside of the exam room so that we can come up with plans that are going to actually work, whether that is making sure patients are taking care of their weight, their volume statuses, weighing themselves, calling us when something feels wrong, um, having someone else that can call us if they can't or if they won't, which is a big thing, right? Because it's human nature to ignore declines until they feel really bad. And so it really is a balance of trying to meet a person and getting to know them, but not just because you want to know who they are. It's that you have to know who they are because it really centers everything that we do. And you have to include their loved ones, whoever is important to them in the conversation. And one thing you need to find out immediately and upfront is if the person that matters the most to them is not their legal next of kin. You need to figure out how to legally bring that voice forward so that we make sure that what the voice that we hear in the time of need is the voice that is reflecting what our patient would actually want for themselves.
I couldn't have said it more eloquently, Dr. Steiner. I also think that it's important to recognize going in that we can't cure all congenital heart disease. And sometimes our role is to walk a difficult path with our patient instead of necessarily to walk the road that they want. And I think forming these deep connections with them and establishing trust so they don't feel alone, even if they're upset and their family is upset about what the outcome may be, them not feeling abandoned and understanding that the team is beside them has huge, huge benefits for them and their quality of life, regardless of what the outcome may be.
Yeah, I agree with you completely. We encounter patients who may have a very different view of what's going to happen than we do. And that is sometimes because there's a ton of unknown, sometimes because we haven't explained ourselves or what we're worried about or what we're seeing in the various tests that we're doing. And sometimes because it's just really hard to walk that difficult path. And it really is so important that we center the idea that we're a team and we're working together to reach the best possible outcome. And even if that outcome isn't decades more of life, that outcome is quality of life and empathy and helping our patients have the emotional support that they need moving forward in whatever their journey might be.
I just want to say that I am so happy that we brought this up during this conversation because, there is this huge question about how we define success in medicine. And there's this mentality of defining it by mortality rates, when in reality, I think success in medicine can be more so, the quality of life you're giving your patients or treating them with dignity and giving them the life that they want for whatever time they have with us. And so I really, really love this conversation.
I agree. It's so wonderful to have a bunch of ACHD providers together. And I know, we all might have our various subspecialties, but I think this global perspective is really a wonderful aspect of ACHD care. We're trying to help our patients live their lives that are realistic goals for themselves. This is very different than some instances of acquired heart disease where we're pivoting, we're changing lifestyles, we're doing things. We instead are typically meeting patients who have had a lifetime of care, and we're trying to understand them and help them live the lives that they want within realistic goals. And I just love getting the chance to speak with everybody on this call about it. I really appreciate how kind of everyone's different contributions to this part of the conversation really centered the patient and as the leader in the conversation, and also kind of highlighted the power of vulnerability on both sides. I feel like oftentimes in medicine, we as providers fear being vulnerable, because we are afraid it will be perceived as maybe incompetence or weakness. And I think I've always felt that when I'm kind of honest and vulnerable with my patients about what I know and what I don't know, it can help to strengthen the relationship and also create a safe space for them to also open up and be vulnerable about their feelings and their fears. And I really appreciated that part of the conversation too. Dr. Tsao, as an ACHD interventionalist, what goes through your mind when performing a high risk intervention, knowing that the stakes are often life or death? Well, I think the first part of that, and this might lead into future discussion points, but it's clear, and listening to everybody on this call, that nothing in ACHD is like a single person's decision. And that is true for all aspects of medicine. But I think within ACHD, everybody involved in these patients' care take a lot of time to know their patients. So, number one, you're never alone. It's never a solo decision. So I just want to make that like very clear. I am just a component of a larger ACHD program and team, and happy to be a part of it. That being said, when it's 3 a.m. and you have a big case the next day, you could feel pretty alone. Um, and you might wake up thinking about a procedure, and there's a lot that goes through your mind. So, number one, I think thinking about risk assessment in these patients, we've already talked about these patients have had a lifetime of care leading up to this. And I'm also a non-congenital structural interventionalist, and you kind of bridge these two worlds where I can talk about TAVR and, edge-to-edge repair. And I have randomized control trials and all this data that you can fall back on in times of high risk that supports you. And in adult congenital heart disease, we are never going to have a 3,000 person randomized control trial that's going to show a mortality benefit for a procedure. This is a very different world of intervention. But having a knowledge of it and understanding your patient's personal risks and their medical comorbidities and what's important to them going into these decisions is going to help you then pull necessary aspects of, other components of interventional cardiology and help frame that conversation. And the other part that goes into this, and we've alluded to it in the earlier conversation, is every patient might come from this in a very different way. There might be different developmental stages. The patient's personal participation in the decision making might be different. There's really a lot that goes into it. So having that understanding is really helpful. If you have the luxury to have a clinic, like I know interventionalists, we love being in the cath lab, but I will say that this is where my clinic time has really become invaluable to me, having the time to sit down with a patient, their family members, their friends, their person, in addition to them sitting face to face, not in a gown, not, in a sterile situation is really wonderful. And I think that my clinic has become a lifeline for what I do. We don't always get that luxury, right? And we definitely have times where patients are in ICU and we need to make decisions and move forward. But I think having that deeper understanding and knowing where we're coming from and what's important is important in phrasing your discussions about risk and benefit for any given intervention, whether it's immediate or you have some time to plan. The other component of this is, since we don't have these RCTs and everything else that we love in interventional cardiology, you also have a patient population and the families and other support people in their lives that are very accepting of the honesty and of the ambiguity. These are people who have been living on the frontier of medicine to even get to where they are as adults living with congenital heart disease. When you're seeing a 60-year-old Fontan and talking about something and you're saying, well, your bleeding risk, we don't really know. Your liver is bad and there's this complication potential and this and this. And they're like, yeah. I've been there. I've done that. I understand. This is just an amazing luxury to discuss with these patients and kind of understand their story and their background and everything that they are bringing to these conversations as well. So again, it's a conversation, as Dr. Steiner brought up beforehand. It's not just coming in and giving recommendations, but that full background goes both ways and is really helpful as an interventionalist.
Wow. Dr. Tsao, it sounds like you make some extremely challenging decisions and have some pretty challenging conversations at work pretty regularly. Do you recall any cases where you really questioned whether or not to proceed with an intervention? And you did brush on the role of multidisciplinary teams when making these decisions. Were there any other key factors that impact your decision-making process?
We deal with patients with complex anatomy and complex hemodynamics. And it's why this is, in my mind, the best field. And also, it's what keeps you up at night wondering. There's no single right answer, right? Medicine is not the multiple choice tests that you take for the boards. This is real life. And you are taking all the inputs, having the multidisciplinary discussions, and sometimes you just need to decide yes or no. And this is, again, multidisciplinary discussions and knowing who you can talk to. So I had a recent very sick patient in an ICU with, I think he was a Rastelli and had essentially a failing conduit and a residual VSD, and as blue can be. And I thought I understood what was going on hemodynamically, but we were dealing with outflow tract obstructions from both ventricles, and it was clear the conduit was the bigger issue at the time. But, I wasn't sure that we were going to even be able to get him through induction to do a procedure. You keep looking for the adult in the room to help you make the discussion, and then you're looking around and you realize everybody's waiting for you to make a decision. But it was really hard. And I think knowing who's in your corner, what person you can turn to look at an echo with you and perseverate on, this flow that you're seeing here, and talking to your heart failure colleagues, talking to any other subspecialists that are in your corner you guys are in this together. I think it's extremely helpful. And then the next part of it is talking to families in high acuity situations. We've already discussed that in the first part, but trying to understand that, this could have an exceptionally poor outcome. I mean, dying in the cath lab, and being okay with that. The benefit is there, but the outcome, and even if everything goes perfectly, we might not reverse the situation. It's really hard. With this Rastelli patient, I'll go back to this again. We took him for a very complex conduit intervention. We actually had his family essentially say goodbye to him, and I stood next to him during induction. It went perfectly. I had just amazing cardiac anesthesiologists with me who, dealt with me while we talked about everything for about an hour before we brought him into the room, and everything really went great. And then we got through that. And then what did we unmask? Like really horrific LV outflow tract obstruction. And then the conversation became, do we do a really high risk TAVR? And at this point, I had spent, I don't know, 5 days essentially being awake with this man deciding, are we going to do ECMO? Or are we not going to do ECMO? And then the next complex decision comes. And we had great people involved in palliative care and transplant and everybody. We were there for several days. And ultimately, um, I declined him for TAVR. And that was not a solo decision. I felt like I was in so deep with the family and him, and he could intermittently participate in these conversations. But you wonder, you want to make the decision. I'm going to get emotional with this, guys, because this is very fresh for me.
I think this speaks to the vulnerability that we all bring to our jobs and the deep connection that we all have with our patients. Our jobs are not easy in the sense that we don't have kind of cut and dry guidelines where things are going to go the way they go. And we're not cookie cuttering anything. Like literally every single case is unique. And I think we, more than most people, are saying goodbye to our patients before we put them under, right?
But I said no to a procedure, and like, was that the wrong decision? I think it was the right decision. Um, and he ultimately died like very peacefully with his family, and it was a good situation.
Like I think this is part of what makes ACHD unique and hard and emotionally challenging and also totally worth it.
Yeah. There are extremely high risk patients that we have these complex discussions over. And, we get everybody together. Everybody's willing to show up in the ICU at the bedside, and we make decisions to move forward. And we, ideally, we can get to a better place and, do an intervention. And then, we're all high fiving. It went well. And then we realize the next problem bears its head. Then the liver starts to go. Then there's a bleeding complication. It is not a single shot. We don't do the TAVR and it's done, but it is one step in a complex disease state that is never cured. And it's part of what these patients and these families have lived through for years. And we are, very lucky to be a part of it. And it's what makes the job difficult. And it's also what gives you, keeps the drive there and brings you back every day and makes the hours in the hospital and everything else worth it, because it's really special. It's really satisfying. And yeah, it's the hardest job, not as a proceduralist. It's a hard job to be an ACHD physician. I'm really lucky to have a fantastic team that I get to work with. And whether that's the team that you're with in the hospital or the team that you know across the country where you can call and review a case with them before you scrub in, it's really special and it's a great community, and more people should do it.
Dr. Tsao, thank you so much for sharing your strategy on how to tackle such, challenging decisions. I also just have to say, seeing how passionate and how driven you are in terms of your work, it's just incredibly special, and it's very nice to see. One more question in terms of your approach in the cath lab. These are very high risk situations. What strategies do you use to maintain confidence and focus under such high pressure situations?
Preparation, preparation, and preparation. A lot of planning and knowing who your team is going to be in a procedure and who you need to talk to up front. And whether that is your patient's anatomy, whether it's their medical comorbidities, all of those things go into it. I write pretty detailed procedural plans for myself, not just for me, but also it really clearly lays it out. And I know I need to talk to my nursing staff, my techs that are going to be involved, the cardiac anesthesiologist. These interventions are different than some of our other standard structural interventions. I'll liken all this stuff to TAVR, which can have its own set of complexities, but a transfemoral TAVR is a pretty spelled out algorithm right now. And to do a complex Fontan intervention, you need to know what resources you have and make sure that anybody who comes in the room, if there is a complication, can also get on board with what's happening. So I actually like to have a diagram that was very helpful in terms of training in a pediatric hospital as well, to know that diagrams are really helpful for everybody to just get a quick visual, know your resources for your cath lab. And I think that goes, if you're going to a place that doesn't do as much ACHD, to know what catheters you could use or pull in, what equipment you have, what coils are available, what covered stents are available. This is more probably nitty gritty interventional cardiology that we don't have to spend as much time with. But the complications of an interventional procedure are the complications of an interventional procedure. There's bleeding, there's rupture, there's need for, conversion to open procedures. There's getting vascular access. So knowing what prior shunts existed, where they might have been cannulated for ECMO in the past. These detailed adult congenital notes are really helpful for the proceduralist or for anybody else that might be involved in those procedures. So yeah, preparation and planning and communication, even with those, people, that anybody in the room is going to be an important part of that procedure.
I'm very curious to hear from Dr. Steiner and Dr. Salciccioli, from the eyes of a non-invasive ACHD provider, what goes through your mind when referring patients for high-risk interventions? And how do you walk them through this extremely difficult shared decision-making process?
I think one of the most important things when you're referring patients for procedures is having trust in your proceduralists. So having amazing interventionalists like Dr. Tsao, having really talented congenital heart surgeons, even the people who further subspecialize to care for adults with congenital heart disease, and having trust that you're sending them to the best team possible is huge in making that decision and having confidence with referring patients. Like Dr. Tsao mentioned, the planning, the multidisciplinary conferences, then making sure that the T's are crossed, the I's are dotted, and that every kind of possible permutation that you could think of complications or successes has been considered ahead of time is so important. In talking about it with patients, I think we talk about the risks and benefits of the intervention, but another really important thing to talk about with them is the risk of not intervening. So sometimes it's not just should we do this or not, but what does it look like if we don't, regarding mortality, short term and long term, their morbidity, their quality of life. And this is where having that long term relationship and working with them to really establish their goals and values when you do have a gray zone in decision making becomes so important. When we don't have a class one indication to do something, or when our class one indication is expert opinion instead of having a stronger level of evidence. And so balancing the patient and their family's goals and values, what we can best estimate as far as the risks of intervention versus the risk of not intervening, and then making sure we set them up for success as much as possible in the leading up and optimizing before the procedure is key. And the other thing that I think is really important, we talk about shared decision making, which is clearly so important, but I also think it's critical for us as the medical team to be able to give our opinion on what people should do if we're asked. These decisions are so complex, even with all of our medical knowledge with our multidisciplinary teams, that I think in many cases it's very unfair for us to say, all right, patient, here's all of the information. So what do you want to do? So I think trying to frame it within their goals and values and make a recommendation if we're pushed to is something really important and really challenging, because then if you have a bad outcome or even a good outcome, there's so much responsibility that falls on your shoulders. And that can be really, really hard to handle as the medical team. But I think it's so important in building that trust and in making the right decision for the patient.
Yeah, I second all of that, especially that piece around kind of recognizing the uncertainty. Um, Sometimes we do things because we see a change on a scan that indicates to us that that person's heart is no longer compensating or managing the extra demands in the way that it used to. And if that person doesn't feel bad, then our recommendation can seem completely absurd. And also knowing that for certain situations, transcatheter interventions are available. But then if we're recommending open surgery, it's so important for us to discuss why and to really have a comprehensive conversation with our patients and their people that are important to them about why we're recommending the harder road or why we're recommending whatever the intervention might be right now, as opposed to 1, 2, or 5 years down the line. And thinking about when there might be flexibility. Do we have to do this next week? Or can we do this 2 months from now when the weather's a little better and it's easier to drive here over the mountain passes or fly here from a place that has bad weather, or when school is out, if our person is, say, a teacher and it's a little bit less burdensome on their lives, is waiting 3 or 6 months going to make a huge difference? And on what are we basing that guess? I think this transparency is really not necessarily unique to ACHD, but I think it's just very front and center because, as you heard earlier, we just don't have these hundreds of thousands of people trials on which we're basing our information. We're extrapolating our data at best from other populations. And the other piece of it is, yes, it is important to have a multidisciplinary team and make sure we're making these joint decisions, but also making sure that we have kind of a backup plan. Thinking about, yeah, it sounds extreme to discuss whether or not we need to be prepared for an urgent transplant for someone that is seemingly undergoing a relatively straightforward intervention. But I think it's really profound how quickly certain things can go sideways, even when we do our best to plan, even when we've looked at the scans and we've talked everything over and we think we've done everything that we can going into a procedure. Sometimes it's worth thinking about what else could happen. And if there is a what else, then what are we going to do? And I'm not a fan of scare tactics. I don't necessarily bring all of this up with my patients, but it's certainly something that we talk about between us, our colleagues and our interventionists and the people that are going to be there front line when things are happening.
It's interesting. We also are in this world where there are always transcatheter therapies that are new and evolving, and how we incorporate that into these patients' care. And when you just don't know, and when you're trying to do something novel, and that it has the potential to really change things, right? When we first started doing TPVRs and everything else, and now it's changed, and now we have self-expanding valves, and now we're using covered stents for more and more novel anatomies. And yeah, there's going to be an ever-changing discussion kind of landscape and incorporation with a lot of people, but then also being honest when I agree with what Dr. Salciccioli said, that, we need to give a recommendation at some point. We can't expect somebody to take 20 years of medical training and then make their decision independently.
So it really sounds like transparency and trust are two key components to successfully navigating these challenging conversations that we have with our patients. At this point, it's pretty clear to us that the field of ACHD comes with its set of challenges. Yet, it's also incredibly important to note that the field is just as equally rewarding. Physicians in this field have the unique privilege of building lifelong relationships with their patients, witnessing milestones that were once thought to be impossible, and using new treatments to transform lives. It's a field filled with hope, resilience, and countless moments of triumph. Dr. Salciccioli, we would love to hear about your experience. What keeps you motivated to continue working in such a demanding and emotionally charged field? And what resources or support systems have you found helpful when dealing with the challenges of ACHD?
This is such a great question, because I really hope Dr. Steiner, Dr. Tsao, and I haven't scared people away with how intense this field is. Finding meaning in work is key to success and to making this something that can be a long-term career. When I meet patients, I tell them all that I do this job to help adults with congenital heart disease live their lives despite having a heart condition. And I spend a lot of time, especially early on after meeting many patients, unwrapping the bubble wrap that these patients have lived in since childhood. My goal is to help them to feel better physically, but also to feel confident to go out there and live. So many times people have told these patients not to do things due to unknown risk. But again, as I talked about, there's risk in not doing things. Watching them light up when they're told they can do things they didn't think they could do is such a rewarding experience.
having them come back with new jobs after travel, with new athletic accomplishments, growing families. Many times people who would not have even survived to adulthood a generation ago are accomplishing amazing things. And sometimes taking a step back to just appreciate how amazing what we do is really, really rewarding. But there are definitely hard days, as we've alluded to already. We can't fix everything. So many things we palliate, and even things that we think are cures, these people still don't have normal life expectancies many times. I really personally struggle with balancing hope and fear of what's to come. Dr. Steiner mentioned earlier some of the long term expectations and how we manage that. But one example I deal with pretty frequently in cardio OB clinic is how do we counsel women with Fontan physiology about having children? So, yes, we can get them through pregnancy, and we've learned so much about doing it safely. But what is their heart going to be like when this baby is growing up? Are they going to make it to see high school graduation? Will they need a heart transplant? Will they be there? We have so little outcome prediction accuracy for any single individual patient that it's really, really hard to be honest with them without coming across as being really bleak. And that's something that I know that I struggle with a lot. Bad outcomes are also really challenging. And I think, as Dr. Steiner and I mentioned earlier, walking the road with them and realizing that our job is not just curative, but also sometimes to walk the path, even if that path is shorter than we want it to be, can be really, really rewarding, both for the patient's family and for us as the medical team. As far as like resources and support systems, I think having a village is so, so important. And this obviously will be the team that you're with at work that you see every day, but also I still have group texts with people that I know from training, with coworkers in other fields at work. We also have like an ACHD millennial and Gen Z group text that's an international group of people where we talk about tough cases or research opportunities or random things that may or may not be cardiology related. But having people who understand what you're going through is so important. Peers can understand where you're at and listen to you vent, and then having mentors who will reassure you that you can get through it and you will get through it, and that they've been through what you're going through is also really, really important in getting through each day. And then finally, we can't talk about dealing with challenges without talking about life outside of work. So I don't love the phrase work-life balance, but I'll just talk about maintaining your life outside of work. But having space to actually disengage from the challenges of ACHD is really important. So unless I'm on call, I really try hard to keep my phone away during family time. I send out my in-basket when I go on vacation. I co-lead a running team at our heart center. And so having that ability to disengage so you can come back fresh is just so important. And I think the perspective on life from dealing with people who have so many challenges on a daily basis helps make all of that life outside of work that much more sweet. But really being able to disengage in from work in order to enjoy it is really important to being able to get up every day and do this.
Dr. Salciccioli, I was wondering, based on your experience in cardio OB clinic, how do you kind of help your patients strike a balance between living in the now and kind of empowering them to make decisions like pursuing a pregnancy if it's safe for them, while also kind of helping them maintain that healthy or realistic long term perspective or goals? I imagine that some patients might struggle with finding that balance. And I imagine that family planning and like pregnancy in particular is an area where that comes up.
This is such a great question and such a hard question. And I don't know if I have the right answer. I definitely don't have, but I'll tell you my perspective on it. This is where I think that having patients bring their families to these conversations is so important to help them take a step back, because the topic of having children is very emotionally charged for all people. Pregnancy is a big topic, and the drive to have kids is very strong for a lot of people. One of the challenges with counseling about pregnancy and short and long term outcomes is the lack of data. So we've harped on this many times already during this podcast, but I think not knowing for each individual person what their risks during pregnancy and afterwards are can be really, really difficult. I find that giving percentages isn't that helpful. So I try to keep it in bigger buckets like low risk, medium risk, and high risk.
and try to be as specific as possible for individual complications for during and after pregnancy. So I think you're at moderate risk of having irregular rhythms during pregnancy, which we would handle X, Y, and Z. I think these would either be annoying or dangerous. And then after pregnancy, I think that you would have an increased or decreased or similar risk to what you did beforehand. And so trying to use big buckets in comparative terms and keeping it straightforward is a way that I try to convey that information. I think some of the more challenging conversations are in higher risk people where there may be disagreement in the family about what level of risk the mother is willing to take on to pursue a pregnancy. And those are always very individualized decisions where having some type of long term relationship and understanding the goals and values and really being able to decide what level of information they're willing to take is. But it really just comes down to having a shared decision making, giving as much information as you can, and then letting them know that you will support them with whatever their decision is, both before, during, and after any pregnancy, or if they choose to pursue other ways of growing their family.
If I could add one thing, I just want to center that the cardio obstetrics conversations that we have with this population, I think it's important for us to remember as trained clinicians, for so many people, for the majority of people in the world, pregnancy is not a medical event. It's a thing that happens. It's a happy time. It's an exciting time. It's full of possibility and anticipation that is not dread. Only when there is a pre existing medical concern do we talk about pregnancy in this medical light, in this negative light. And I just want to center that as we talk about cardio obstetrics clinic, because part of what we're used to doing in non cardio OB appointments is talking about now versus the future and the risks and the things that might go wrong. And those conversations are so much harder in cardio OB, I think, because we're starting at a different place of kind of dashing happiness and injecting negativity in a place that society tells you is supposed to be happy. And so I think cardio OB clinic is extra important to connect with people and to know what's important to them and to tell them what you're thinking, but not be all doom and gloom unless you're really, really worried that something's going to happen, and being transparent about why. Um, I think is just so much more important in that setting than even our other appointments.
I completely agree. And as much as I focused on the really challenging conversations, like Dr. Steiner alluded to, a lot of our patients can do really well. And so a lot of my cardio B clinics are actually telling people that they're not as high risk as they thought. In the past, anyone with a heart condition of any kind was told they needed a C section. And now the group of people we recommend that for is really, really small. So in general, I think that the more we watch how people do during pregnancy, the more data we have, the more specific we can be. But I think Dr. Steiner again just mentioned, I think finding ways to avoid being overly negative and to not oversell risks when we don't know what the true risk is. Again, like I mentioned before, that's the challenge, is wanting to not rain on people's parade while we're still being honest and realistic with them.
Thank you both. That was a really great reminder to help your patients enjoy the moments in life that are special, and to do what we can as clinicians to unburden patients and empower them with knowledge that's going to be helpful to them, but also do what we can to ensure that they're able to live their lives with joy. This is for any of our speakers. What advice would you give an early career physician about maintaining emotional resilience in this specialty?
I think the training is long, and that's okay. I think, as you can hear from all of us on this call, I think we all really love what we do, and the patients and what we do brings us back every day. We talk about balancing our lives and enjoying life in and outside of the hospital. Know that some days and some nights are going to be really hard and you're going to feel like you don't have balance. That's okay, right? That everything has perturbations in life, right? We move towards chaos and entropy, and that's all right. So forgive yourself for having bad days or feeling like you don't feel like a failure when you don't feel like things are well balanced. That's okay. That's all part of the process. And if this is something that you're really passionate about and want to be doing in your life, it is absolutely worth it. And there are great moments getting to be there to hold your patient's baby after they never thought they were going to be able to have a child, and you can help them along that pathway through pregnancy. It is absolutely amazing getting them through like a complex intervention and let them, run a marathon that they never thought they could do. These are all huge benefits that it makes the long nights and the long days really worth it.
I went into cardiology initially because there were rules, there were protocols. It seemed like we knew a lot about what to do, and it made sense. And ACHD makes sense too, but in a very different way and with many less rules. And I think part of what is intriguing and exciting and what makes it completely worth it is that we are wading through uncertainty every day. And while that can be difficult, it can also be really exhilarating. And it is often in those circumstances where it feels worth it because you're really making a difference. And I think it's also important to remember that ACHD is absolutely a team sport. No single person is going to solve the problems in this field. And it really does take all of us. I think we all feel like one big family in a way, maybe because we're not that big yet as a group of clinicians, but it's so important to lean on each other and to not feel like you have to do this by yourself, which is how I think we're all sort of taught to be up until you get to this fellowship, right? We're all taught to have all the answers. And even if you don't have them, go find them or pretend you have them. And that's not how we operate in ACHD. We talk to each other, we ask friends and colleagues for advice. And I think the hierarchy is just a lot more flat because we recognize that we're all learning together and one person's experience could be exactly what someone else is looking for. And that goes a long way when you're trying to enter this field and persist in this field moving forward.
I couldn't agree more with both of you. I think celebrating the big wins, the successful pregnancy, the great outcome after surgery, especially those that we spoke about earlier with the toil over the decision making. When you get it right, it feels great. And that's such a great time to celebrate with your team and help build your trust together. We mentioned earlier, but finding your people both at work and nationally is so huge. We're always asking each other questions and learning from each other. It's just so important. And then zooming out a little bit, just remembering that your job is not your whole person, that bad outcomes are going to happen no matter how good our decision making is, which is really, really hard to handle for all of us perfectionists. We want to know that if we make the right decision, we'll have a good outcome. And that's just not always the case in congenital heart disease, unfortunately. It is a lot of the time, but not always. And you can't let it get you down. Zooming out a little bit and a little bit less ACHD specific is the idea of imposter syndrome, which comes up a lot in early faculty life. I really like a quote from Adam Grant that says, "Imposter syndrome isn't a sign of inadequacy. It's a normal response to high internal standards and a potential catalyst for growth." And I think this is so important in CHD specifically because no matter how sound our decision making is, there will be bad outcomes that can cause you to really second guess your decision making and whether or not you're cutting it. And I think that no matter how good your decision making is, there will be bad outcomes at times. And you have to get up and learn from it and make the right decision again, even if you had a bad outcome the time before, in order to be able to make it to the next day and to bounce back even more resilient than you started.
As someone who's about to dive into the world of ACHD very, very soon, this advice couldn't have come at a better time. The complexity of the field is very obvious and it comes with its, fair share of challenges. But knowing that these setbacks don't define us or our success is incredibly reassuring. it's, this is a great reminder that our growth comes from persistence, perseverance, learning, and just trusting the journey. So thank you so much for sharing your perspective in this.
I can't help because I think some of us have a Hopkins tie here, but medicine, regardless of your specialty, is not about the decision that you make, but it's how you make the decisions. And I think that is a core tenet in medicine and the Oslerian way. And we need to get rid of the thought that there is the correct decision to make. It's who you talk to, how you come to these decisions, and working with the right people.
The common theme that's come up of this being very much a team sport. And it was evident at the beginning of this call how you all know one another and there's a trust between the different ACHD providers that's, I imagine, built from a lot of experience of leaning on one another. It's very inspiring and I think really a very special thing about this field. As we've heard today, the field of ACHD is one of extraordinary complexity, both medically and emotionally. It's a specialty that demands not only technical expertise, but also deep compassion, resilience, and a willingness to walk alongside patients through every stage of their journey. We hope this episode has shed light on the unique experiences of ACHD providers and offered insights into how they balance the highs and the lows of this deeply personal field. Thank you, Dr. Steiner, Dr. Tsao, Dr. Salciccioli, for sharing your experiences, insights, and wisdom with us today. Your dedication to the field, as well as your openness to discuss both the challenges and rewards, are truly inspiring. To our listeners, thank you so much for joining us. And to Rawan, our future ACHD fellow, thank you for leading this as part of the CardioNerds ACHD Council. Until next time, take care. I just wanted to thank you, Dr. Tsao, for being so open. I was really moved by your story. And personally, I feel like this discussion with everyone being so deeply compassionate and thinking about the care that they provide through such a humanistic lens. And it's so clear that you all care so deeply about your patients. This sort of ethos is really what has drawn me to congenital heart disease. And so, I just wanted to thank you for that.
Thanks, Claire.